لا مش خالص مش حاسس اني لوحدي، انت معايا.
أكيد. أنا معك وما راح أتركك لوحدك. خذ راحتك في
ولا
الكلام
تتركيني
أو
انا.
لو تحتاج وقت وأنا جاهز لأي دعم تحتاجه.
وساعديني.
طبعا. أنا هنا عشان أساعدك بأي شكل تحتاجه. لو تقدر.
ممتاز. نحن حنشرح حالة الديابيتيك كيتو اسيدوسيس in children.
ممتاز. هذا موضوع مهم جدا. هل
how
عندك تمام.
yes, how can patient come to ER if you are a doctor in ER and one patient come to you? What's the symptoms you suspect that baby is DKA?
Exactly. So, in the ER, if a patient comes in, especially a child, some of the key symptoms you'd suspect for diabetic ketoacidosis are things like vomiting, abdominal pain, rapid breathing, confusion, and
Yes, I
sometimes
know,
even a
I know. Vomiting, abdominal pain, rapid breathing, called cosmal breathing. Sometimes you smell acetone
ex-
in breath. Yes,
yes, that's right. And you'd also see things like fatigue, possibly dehydration, and often their blood sugar would be very high. So, it's
yes, of
crucial to
course. So any patient come to you, you should do first bedside glucose. Yes.
exactly. So, once they arrive, you'd want to get a fingerstick glucose test right away. And if it's high, you'd follow up with a serum glucose, check their electrolytes, and do a basic metabolic panel to see if they're heading toward DKA.
Yes, I know the patient after you stabilize patient, you should take history and perform physical examination. Con- Concentrate on glycoma scale and pupil size.
Exactly. Once the patient is stable, you'd gather a detailed history like any previous diabetic issues, symptoms onset, and then a
Yes,
thorough
yeah.
physical.
Sometimes diabetes may become new onset DKA
Ex-
or maybe non-case of the diabetes mellitus. Yes,
Yes, that's a really good point. Sometimes kids can present with new onset diabetes, and the first clue is DKA. So
yes,
it's super
but
important.
you have to detect if the patient in shock state or not in shock state. Yes.
Absolutely. Yeah, so
Yes,
you
if the
check.
patient in shock state, we can give bolus normal saline over 30 minutes to one hours, 10
Exactly.
10 ml per kg per hour.
نعم، بالضبط. فبتعطيهم بولس من محلول ملحي وغالبا تكون الجرعة 10 إلى 20 ملي كل كيلوغرام
لا نحن
وبمعدل.
بالدي كي بنستخدم 10 بس، مش 20.
أيوة، تمام. في حالة ال DKA فعلا نستخدم 10 ملي كل كيلوغرام عشان نكون دقيقين في تعويض السوائل.
ايوه، لان لو اعطينا سوائل اكثر ممكن البيشنت ريسكي اوف سيربرال اديما. صحيح.
بالضبط. وهذا شيء مهم جدا. فزيادة السوائل بسرعة ممكن تسبب وذمة دماغية. فإحنا نكون
ايوه.
حذرين ونراقب الطفل عن كثب بعد البولس.
اوكي. After bolus, we have to check the baby if in shock or not by capillary leafing time, by peripheral extremities called peripheral extremities, wake pulse, or prolonged capillary refilling time, or hypotension.
Exactly. Yeah, so after the bolus, you'd reassess frequently. Check capillary refill, monitor their heart rate, look for any signs of poor perfusion, and then adjust fluids as needed based on their response.
Okay. Now this baby bedside glucose is 500, 450.
Right. So with a glucose that high, you definitely have DKA on your hands. So now, after stabilizing, you'd start a slow insulin drip, usually with a
No, no, no,
continuous.
no, no. I will not start insulin drip from first hours. The insulin should postpone after first hours.
Ah, you're absolutely right.
Mm.
Yeah, so in the first hour, you just continue to focus on fluid resuscitation.
I
Then
will
after.
I will focus on fluid resuscitation. Okay, and I will stabilize the patient. The patient need oxygen or non need oxygen. I will give him fluid. I will extract blood and send blood for CBC, CRB, blood gas, blood ketone and urine ketone, electrolyte. If the patient febrile, I will send him for culture of blood. Yes.
Yes, that's perfect. So you'll cover all those bases fluids, labs, and vitals. And definitely, if the child is febrile, you want to check for any infections. Once you get those results, you'll have a clearer picture of the cause and next steps.
Okay. Neuro check. I will reassess neuro check Q half hour. Yes.
Exactly. Yeah, so you'll do a neuro check every 30 minutes looking for any changes in their level of consciousness, pupil response, or any new symptoms. That way you catch any complications early.
Okay. Now the blood gas came to you. pH 6.9, bicarb 4, and urine ketone is 3 plus, and your job high.
Yeah, so with those results, it's pretty classic DKA. The pH is very low, bicarb is really down, and the high anion gap confirms a metabolic acidosis.
Yeah, metal,
So now
but
you'll
severe,
definitely
severe.
start the
It's
insulin drip,
not
correct the electrolytes, and continue monitoring
yes,
closely.
this is not mild. This is severe. Yes.
Exactly. This is a severe case, so you'll really need to keep a close eye on them.
Yeah.
Watch for any signs of deterioration and be ready to adjust the treatment if needed, especially
Uh,
the potassium levels.
So, in order to, we will classify DKA mild, moderate, severe. Mild venous pH 7.2 to 7.3, bicarb 10 to 15, moderate venous pH 7.1 to 0.2, bicarb 10 to 5 to 10, severe, bicarb less than 5 and pH less than 7.1.
Yes, exactly. So, based on those criteria, this baby falls into the severe
Until now,
category.
we not start insulin.
Exactly. Yeah.
We
So,
will do
once the first
ECG and AR. If available, we can do ECG. You can see the T wave change. Yes.
Yes, exactly. So if you have an ECG available, you definitely want to check for any T wave changes, since hyperkalemia can be a risk with DKA. So it's really
Yes.
important to monitor that closely.
Now we will shift patient to BICU. We call senior BICU. We call endocrine. Then shift patient to BICU. And BICU we will calculate the fluid for
Ex-
48 hours. We will use double maintenance fluid in 45 hours, then deficit. We calculate deficit according to the severity of dehydration. Maybe use from 7% to 10. It's better to start 7%. It's okay. Then we will minus fluid plus an AR given. We will subtract from the total fluid. Yes.
Exactly. Yeah. So once you've calculated the deficit based on that percentage, you subtract what you've already given as a bolus and then distribute the remaining deficit over the next 48 hours. That way you correct it gradually and safely.
Yes. Okay. Then after that, we will start insulin. From second hour, we will start short-acting insulin. We will prepare insulin 50 ml of normal saline, then 50 unit of insulin. Give 0.1 ml per kg per hour. Yes.
Exactly. Yes. So from the second hour, you'll start that insulin infusion at zero point 0.1 ml per kilo per hour. Then you'll keep a close eye on glucose levels, adjust the insulin if needed, and watch electrolytes closely.
Okay. So if the baby young or mild acidic, we can start 0.05 unit per kg per hour. Yes.
Yes, exactly. If the
And this
baby is
patient need monitoring. Monitoring, we will put chart, input output chart, neuro check Q1 hours, glucose Q1 hours, blood gas Q2 hours, KFT and blood ketones Q4 hours, urine ketone unvoiding. Yes.
exactly. Yeah, so we'll keep a close eye on everything. Input and output chart, neuro checks every hour, glucose every hour, and then the labs like blood gases every 2 hours and the electrolytes and ketones every 4 hours.
Okay.
That way
So the goal of therapy is to correct dehydration, correct acidosis and ketosis, and normalize blood glucose. We
exactly.
cannot
That's
drop the glucose more than 50 to 1 milligram per deciliter per hour to avoid cerebral edema.
Yes, exactly. So we have to slow down the drop, monitor carefully, and make sure we avoid any rapid shifts that could put the
Okay.
baby.
Then sodium. Sodium we cannot decrease rapidly or correct rapidly. Only a low 0.5 milligram per hour or 12 milligram per 24 hours.
Exactly. Yeah, the sodium correction has to be really gradual as well. No more than zero point 0.5 milliequivalents per hour or 12 milliequivalents in a 24-hour period. So we avoid osmotic issues.
So when we prepare fluid, we will prepare 5 batch. One batch containing 5% dextrose, second bag normal saline, no dextrose, third bag dextrose 10%. And add potassium to each bag, add potassium 40 milligram kcl. Okay.
Yes, exactly.
But
So,
if the potassium is high, 5.5, we cannot add potassium.
yes, that's correct. If the potassium is already elevated, then you hold off on adding any potassium until it drops. So, you'd monitor it closely and only add it once the levels are safe.
Then, according to the reading of blood glucose, we can shift if random glucose between 250 to 300, we can shift to 5% dextrose, normal saline. Yes?
Exactly. Yes. Once the glucose drops to that range, you shift to 5% dextrose in normal saline to keep
Yeah.
them from dropping too
Okay.
quickly.
But if less than 150, we shift to 10% normal saline. 10% dextrose, normal saline.
Exactly. Yeah, if it drops below 150, then you switch to 10% dextrose in normal saline, just to keep the glucose stable as you continue to bring them back to normal.
Yes. So the aim of insulin is not correct only glucose. The aim of insulin is to correct acidosis and ketosis.
Exactly. Yes, the insulin is there to drive down the glucose, but more importantly, to correct the acidosis and clear the
Oh,
ketones. So once the acidosis improves, you can adjust the insulin accordingly.
okay. Now patient is clinically improved. What is out of decay? When we inform the patient is out of decay, if pH, if blood gas, pH 7.3, bicarb more than 15 and sometimes 18, ketone in the blood is less than 1 millimole, and baby to tolerate oral feeding, we stop decay protocol. Yes?
Exactly. Yes, once the pH is above 7.3, bicarb is rising above 15, ketones are negligible, and the baby is stable and tolerating oral feeds, then you can safely stop the DKA protocol. And
Okay.
of course, you continue to monitor after that.
Okay. We start subcutaneous insulin and then stop IV insulin after 30 minutes. First, we start subcutaneous, short anti-subcutaneous, and then after 30 minutes, we'll stop. We will stop insulin infusion. Yes?
Exactly. That's the way to do it. So once you've started the subcutaneous insulin, you give it about 30 minutes overlap, then you can stop the IV infusion. And after that, you just keep monitoring glucose and watch for any rebound.
Okay. Thank you. Thank you very much. You helped me a lot.
You're very welcome. I'm really glad I could help. If anything else comes up or you need to discuss more cases, just let me know.
Okay. I will ask you, Yani, out of this lecture, if potassium is 2, what I will do?
Ah, great question. If the potassium is that low, you'd need to hold off on insulin for a bit because insulin
Okay,
drives potassium.
hold off insulin. Okay, good. Second question. What if the after 8 hours the acidosis is not corrected? Still pH low and bicarb low. What is the cause?
Ah, good point. If after 8 hours the acidosis isn't improving, you have to think about a couple things like a possible infection, an incorrect diagnosis, or maybe a missed cause like corticosteroid effect or other metabolic issues. So you'd reevaluate and consider other causes.
Evaluate and consider other causes. Thank you. How if the patient develop high anuria, no urine output? What I will do?
Exactly. If the patient develops anuria, you need to think about acute kidney injury. So you check for prerenal causes like dehydration or maybe a contrast exposure, and you'd get a renal ultrasound to look for any obstruction. And of course, you would adjust fluids and consider nephrology consult if it doesn't improve.
Okay. If you treat the DKA in BICU, then suddenly patient develops severe headache, drowsy, hypertension, irregular respiration, bradycardia. What is this?
Yes, exactly. So those are classic signs of cerebral edema. So at that point, you need to act immediately. Raise the head of the bed, give hypertonic saline, and notify the team urgently because this is a serious complication.
This is cerebral edema, the complication of treatment of DKA. So I will refer to, I will give mannitol or hypertonic, then shift to CT scan to do CT scan, okay, and involve in neurology and pediatric endocrine and BICU consultant. Yes.
Yes, exactly. That's the right approach. Once you give the hypertonic solution, you immediately get a CT scan, involve neurology, peds endocrine, and the ICU team, and then you keep a close watch on the baby's neurostatus.
Okay. Thank you very much. ساعدتني كثيرا.
العفو، هذا واجبي. إذا احتجت أي مساعدة ثانية في المستقبل أو عندك أي أسئلة أخرى، أنا دائما جاهز. بالتوفيق لك.